So, very good afternoon. We are starting our Q&A. A good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to extend heartfelt welcome to esteemed DDG Madam Dr. Shobini Rajan, the directors and teams from NITRD, NIRT, and NTI. State TB officers, directors of STDCs, faculty members of medical colleges, district TB officers, medical officers, and team of case presenters and experts. I welcome you all to today's meeting. It is also my privilege to welcome our Padma awardee, Dr. Rajendra Prasad sir. Sir, a very warm welcome to you. I am Dr. Neeta Singla. I am the Nodal Officer of DRTV Center at NITRD, and it is my honor to introduce my faculty. On my right is Dr. Rupak Singla, who is consultant in the Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is a senior pulmonologist at NITRD. And now I invite our director, Dr. Upasana ma'am, to give her introductory remarks. Good afternoon, Upasana ma'am.
Hello, ma'am. Your voice is speaking.
Ma'am, are there two devices logged in your room?
No, ma'am. Only one. Okay, I won't take long. And I will just welcome everyone. Respected Dr. Rajendra Prasad sir, Dr. Dr. And of course, our team of Drs. Rupak Singla, Dr. Neeta Singla, and Dr. Saroj Meena. Welcome, and I want to welcome all the esteemed dignitaries who are here today. And I also am very happy to see that Dr. Kumar Saurabh will be talking about post-TB lung disease today, which is such an important problem of TB that is emerging now. So, with these few words of welcome and thank you for joining the session, I hand over the mic to the NITRD.
Thank you so much, ma'am. Your voice was better later on. I think initially there was some technical glitch. We've just got a message from Dr. Shobini that she's not able to join. She's stuck in some meeting. So we straightway go to our case presentation. So today's case presentation is from state of Himachal Pradesh. And we have Dr. Kumar Saurabh, who is a postgraduate student in Department of Pulmonary Medicine, Indira Gandhi Medical College, Shimla in Himachal Pradesh. The state expert is Dr. Malay Sarkar, who is professor and head Department of Pulmonary Medicine at Indira Gandhi Medical College in Himachal Pradesh. Our national expert is Padma Shri awardee Professor Dr. Rajendra Prasad sir, who is also the vice chair for the National Task Force, and he's a director medical education at ERA's Lucknow Medical College. And our clinics expert is Dr. Rupak Singla, who is consultant in Department of TB and Respiratory Diseases at NITRD. So with this, we begin today's academic deliberation. I invite Dr. Kumar Saurabh to make the presentation for the case.
Good afternoon, everyone. It's a huge opportunity to present in such a huge platform. Today, I'll be presenting a case of non-tuberculosis mycobacterial pulmonary disease and pulmonary TB, which is a very interesting case. And so my patient, a 60-year-old female housewife by an occupation, she was from Hamirpur and was admitted at our hospital IGM Shimla Pulmonary Medicine Department on 9th of May 2025 with a complaint of cough, hemoptysis, and shortness of breath. Cough was intermittent in nature, dry, usually occurs at night time since 2 years. Its intensity and frequency was worsening since last 6 months, and hemoptysis, it was also intermittent in nature, streaking for 6 months. Shortness of breath was present since 4 years. It was initially episodic but persistent since last 2 years. When she presented to us, It was of grade 4 MMRC and it was not associated with any positional dyspnea. Regarding the negative history, there was no history of loss of appetite, no history of fever, there was absence of night sweats, and no history of significant weight loss was there. Means B symptoms were completely absent, so it was less likely to be a case of tuberculosis. Regarding the personal history, she was having several comorbidities like type 2 diabetes mellitus, hypertension, bronchial asthma, dyslipidemia, and allergic bronchopulmonary aspergillosis. She was non-smoker, non-alcoholic, but she had a exposure of biomass fuel smoke. Regarding the treatment history, she was on multiple courses of short-term systemic steroids over the last 4 years for asthma exacerbation, and for asthma medication she was taking formoterol and budesonide combination as a meter dose inhaler 400 microgram twice a day since last 4 years. She was also taking tiotropium, toracap 18 microgram OD was also added since last 6 months. For allergic bronchopulmonary aspergillosis, she was taking itraconazole. Itraconazole was started initially, and then it was switched to systemic steroids, and this treatment was started from Hamirpur. She was not having any history of anti-tubercular drug therapy in the past, and no history of TB disease in the family was there. Regarding the physical examination, BMI was low, that is 16.97. Since he was a known case of hypertension, so BP was slightly on a higher side, that is 158 by 94 millimeter of mercury. It was measured in a supine position from the right arm. Regarding the saturation, it was 91% with nasal cannula. Pulse rate, it was 97, regular in rhythm, normal volume. Respiratory rate was on the higher side, slightly higher side, that is around 25 per meter, 25 per minute. Pallor, cyanosis, clubbing, jaundice, it was all absent, and GVP was not raised. Fetal edema was not present. Regarding the systemic examination, respiratory system, accessory muscle was in use because patient was in respiratory distress, and on auscultation, bilateral diffuse polyphonic bronchi was present. On CVS examination, S1, S2 was present, normal, no murmur was there. Other systemic examination was absolutely normal. These are the blood investigation. Here we can see certain abnormalities like sodium, it is on a lower side, that is 130 milliequivalent per deciliter, but no sign and symptoms of hyponatremia was there. HbA1c was on a higher side, that is 10.70, and random blood sugar was 228 on the day of investigation. And also QCRP, we can see that it is on higher side, that is 19.32. Vitamin D was also low. Here we can see that vitamin D, since it plays a very important role in innate immunity, so we can say that innate immunity was also compromised in this condition, in this case. Regarding the microbiological investigation, sputum for smear microscopy was sent for CB-NAT. It was turned out to be negative. Bronchoscopy was done at Hamirpur on 23rd of November 2023, and BAL was sent for CB-NAT as well as for MGIT 960 culture. Here we can see CB-NAT was negative, but MGIT 960 culture, it was positive. And also immunochromatographic test was done at intermediate reference lab Dharampur, and it was negative, which was suggestive of non-tubercular mycobacterial infection. For species identification, we have sent the sample at National Institute of Tuberculosis and Respiratory Diseases, New Delhi, and species was identified as Mycobacterium abscessus. And for the further management, she was referred to the ICMC Shimla. This is the final diagnosis of the patient, that is Mycobacterium abscessus pulmonary disease, macrolide resistant and cavitary variety. And we have started the treatment of Mycobacterium abscessus based on DST, and DST report was DST report came very late. I'll explain all those timeline in a time span in the next slide. This is the basic diagnostic criteria of non-tubercular mycobacterium by IDSA 2020 guideline. For the diagnosis of non-tubercular mycobacterium, it needs to fulfill three main criteria. One is clinical, another is radiological, and third one is microbiological. In clinical, pulmonary or systemic symptoms must have to be present. Radiological, nodular, or cavitary opacities can be present. And if we talk about the microbiological, we can send microbiology in the form of sputum also. But if you are sending sputum, we need to send two samples. If you are sending bronchoalveolar lavage as a sample, one sample is sufficient enough. And also we can send endobronchial biopsy or transbronchial biopsy. In the biopsy, we can see granuloma in as a histopathology, as well as sputum or bowel needs to be culture positive. This is the report which we have received from National Institute of Tuberculosis and Respiratory Disease. This is a drug susceptibility testing. On the basis of this DST report, we have started the regimen for the patient. Here we can see that Mycobacterium abscessus is a very notorious bacteria, that it is resistant to almost all of the antibiotic except imipenem, which is showing intermediate resistance in this condition. And remaining all macrolides like clarithromycin, amikacin, all those are resistant in this condition. So we can say that Mycobacterium abscessus is a very notorious bacteria in this case. This is the serial X-ray which we have done in the course of management. On the left hand side, we can see that this X-ray is of when the patient was admitted to us on 9th of May 2024. We have done the X-ray. We can see that there is a inhomogeneous opacity present on the right mid zone, which is suggestive of cavitation. Then we have also done X-ray on 29th of July 2024. There also inhomogeneous opacity is present on the right mid zone with cavitation. And on 23rd of November 2024, we can see there is a thin walled cavity on the right mid zone. This is a CT thorax. This is a lung window, which is showing patchy consolidation with cavitation in apical segment of right lower lobe. It is done on 21st of November 2023. And on the right hand side, CT thorax was done on 18th of April 2024. It is showing patchy consolidation on the right perihilar region of right lung. This is the basic pre-treatment evaluation which we have done before starting the treatment for the patient. Audiometry was done. Baseline ocular examination. The audiometry was done because we were starting amikacin over here. So we have done audiometry, so that because amikacin has a very important side effect of ototoxicity, that's why audiometry is done. Baseline ocular examination was done, psychiatric evaluation, baseline echo, and ECG was also done. As per Fredericia criteria, QTC was 400 millisecond, which was less than 470 millisecond for the patient. So it was normal, so we can start the macrolide in this condition. Regarding the treatment regimen, IDSA 20, as per the IDSA 2020 guideline, there are the certain preferred regimen which we can use in this condition. But there was certain resistance in as we have received drug susceptibility DST report from NITRD, so we have modified the regimen. But as per the guideline, the preferred drug in the initial phase, we need to select any two parenteral drugs from amikacin, imipenem, cefoxitin, or tigecycline. Among oral, we can choose any two or three drugs. Like azithromycin or clarithromycin, clofazimine, or linezolid. In continuation phase, we can select any two among these three drugs, which is azithromycin or clarithromycin, clofazimine, linezolid, and inhaled amikacin. But we have modified the regimen because patient the DST, as per the DST report, their Mycobacterium abscessus was resistant to certain macrolides as well as other antibiotics. After 3 months, continuation phase, smear microscopy was turned out to be negative in 3 months only, and MZ960 culture was negative at intermediate reference lab Dharampur. on 28th of August 2024. So we have started, we have given the regimen like tablet AZ 250 250 milligram OD as an immunomodulator. Tablet clofazamine was started, tablet ciftinir, and ferropenem with rifampicin, because these two are synergistic with each other. So we have started this regimen. Again, the patient was admitted, readmitted to our hospital as a acute exacerbation of asthma, as she was presented to us with worsening shortness of breath and cough, and absolute eosinophilic count was 2040 per cubic millimeter. Serum IgE was more than 3200, but ABPA panel was normal. We have done ultrasound of a patient, and it was showing grade 1 fatty liver. Clinical hematologist opinion was taken. Echo was advised to rule out pericardial effusion. Echocardiography showed concentric LVH, and albendazole was also given because eosinophil count was more. The second clinical event occurred again, and again patient was admitted to readmitted to our department on 26th of January 2025 with a history of fever, hemopsis, anorexia, worsening cough, and shortness of breath. Here, a new radiological shadow appeared on the left lower zone, which we can see in the right hand side X-ray, that there is a opacity over the left lower zone. This X-ray this X-ray was done on 16th of January 2025. Video bronchoscopy was done on 28th of January 20. After admission, video bronchoscopy was done, and on 28th of January 2025, sputum was sent for NAT, as well as BAL was sent from bronchoscopy. Sputum was turned out to be negative, but BAL was in BAL we have detected Mycobacterium tuberculosis complex and rifampicin sensitive. So category 1 ATT was started for the category 1 ATT was started along with Mycobacterium abscessus treatment. And also we have done CT scan on 22nd of January 2025, which we can see over the right hand side. These are the serial X-ray which we have done in the course of management when the patient was admitted to our department after diagnosis of TB. Here we can see that there is a gradual healing of the patient. This is the latest X-ray which patient presented to us at the end of treatment when we have started the regimen after DST report, and when culture was negative, after culture was negative, we have completed the treatment for approximately 18 months, and after that patient presented to us, and this is the X-ray which is showing completely healing of the patient, and treatment was started. Treatment was stopped after 18 months after culture negativity, and radiological stability is present over here. Sputum was negative again. This is the basic timeline which we can see over here. On the 23rd of November 2023, bronchoscopy was done at Hamirpur and BAL was sent, and Mycobacterium abscessus was diagnosed, and DST was received on 18th of May 2024. After that, we have started the treatment for Mycobacterium abscessus on 22nd of May 2024. But over here, we can see that we are sending BAL on the month of November, and we are receiving DST report after 5 months, approximately 4.5 to 5 months. So there is a huge gap, means huge time span, long time span, that we are not able to start the regimen as early as possible, because we are receiving DST report very lately. That's why this is a very important thing. And on 28th of August 2024, MZ 960 culture was negative. It's a very short duration of time that within 3 months of treatment, culture was turned out to be negative. On 28th of January 2025, she was again readmitted, and on that day, BAL was sent, and BAL was turned out to be positive for Mycobacterium tuberculosis complex, for which category 1 ATT was started. For Mycobacterium abscessus treatment, it was stopped after 18 months after culture negative report. that is on February 2026, and patient is now better with minimal cough. This is the basic trend of QCRP. On the left hand side, we can see that QCRP was raised on 16th of January 2025. It is the period when patient was detected with Mycobacterium tuberculosis complex. That's why CRP was more in this condition. Also, there is a slightly weight loss in around the month of January 2025. It is also the same period when the TB was detected in the patient. So here we can explain by the same mechanism. And regarding the HbA1c, we have also given the treatment for diabetes, and there we can see that patient is improving now. Now I'm handing over presentation to our sir, Dr. Malay Sarkar.
So all the culture of the patient, it showed negative report. So there is sustained culture conversion in this patient. So that's a good sign in this patient. So why we have chosen this regimen? Because you can see in patient of Mycobacteria abscessus, macrolides and amikacin are the two drugs which usually show clinic in vitro and in vivo correlation, but other drugs they usually don't show. But still the regimen in abscessus should be based on DST report. Here you can see except imipenem, which is showing intermediate response, all other antibiotics they are resistant. So because of that we have to use the pharmacological phenomena which is called synergistic response. So when two drugs showing high MIC, if you combine the two drugs together, certain combination had shown significant fall in the MIC within the susceptible range. So what we have done, two beta-lactam combination in this patient. One is imipenem and cefdinib, and there are also many other studies which suggested ferropenem and rifampicin. If you combine, their MIC will come down to the susceptible range. So we have used two synergistic combination in this patient besides macrolides, which should not be counted as a anti-TB anti-MAB drug in this case because of resistance, but we have used it because of immunomodulatory effects. And if you look at the treatment response, there is a need to know the subspecies of the Mycobacteria abscessus. There are three subspecies, abscessus and bolete. Usually they show poor response because of inducible macrolide resistance, and mesilians the response is better. So in our patient we are not sure whether which subtype of patient we are handling, but macrolide was resistant. It can be either inducible resistant or it can be mutational resistant of the RLL gene. So our patient, the BMI was low, and low BMI is an important prognostic factor not only in TB, even in NTM patient. And we have taken necessary nutritional measure for our patient, and she has gained weight over the period of time. So this is the report, 5 years report from Himachal Pradesh. You can see like the figure from other area, MAC is the most common identified NTM, and then we have Chiloni, Fortuitan, abscessus patient. One interesting point in all these cases, there is a diagnostic delay, and many of these patients they took anti-TB therapy before coming to tertiary care center. So one important point I want to highlight here, if the patient's smear is positive, CBNAT is negative, we must suspect NTM patient. Besides that, there are certain category of patient like bronchiectasis, person having destroyed lung, post-TB lung damage, we have to think about NTM also, because it's a progressive disease. You can see the X-ray on the left side, there is significant lung damage. So it's being a progressive disease, we need to diagnose this condition earliest, and we have to put a guideline-based therapy at the earliest. So there are certain challenges. It's a neglected disease. Misdiagnosis is very frequent. Delayed diagnosis also, as I have told you, most of the majority of patients here we have seen they have been given anti-TB drugs before being referred to tertiary care center. Already 3-4 years gone, and by that time disease has progressed significantly. It's not a notifiable disease, and so not being enter on NITRD. So there is open we face the challenge of getting all the anti-TB medication for our patient. Turnaround time lab is definitely an issue which needs to be solved. We should have linkage to nearby lab so that we can get the. Ideally, we should have this facility of identifying the species and DST in Himachal only. Poor adherence to guideline-based diagnosis and therapy is a real issue. Two sputum must be sent because it's an environmental pathogen. We should not start treatment on the basis of single sputum. And while sending the sputum, we must tell the patient that don't rinse mouth in the morning with tap water. Otherwise, there is a chance you can get false positive report. Usually, it's not transmissible, though there is some case report. MAP can be transmitted in nosocomially in cystic fibrosis patient. Issues related to drug availability. When you are dealing with a patient with multi-drug resistance, you need to start salvage therapy. Then you may face this issue. So I have 4-5 questions. Why did the patient become MTB complex positive despite on rifampicin and several other drugs having anti-TB effects? And then what is the role of bedaquiline as a salvage regimen? Risk factor for NTM in this patient? Any role of Mendelian susceptibility, because initially she has developed NTM and then she contracted MTB, and certain program related issue and future perspective. So these questions are open for our expert. Regarding the first question, I just want to express my view. Probably there is a competition between NTM and Mycobacteria TB within the airway microbiome. So when the NTM number starts falling, the MTB complex then takes over the NIC. And secondly, the granuloma, might have walled off the MTB bacteria along with NTM, but after treatment for NTM, the granuloma, the walls break down and MTB complex were detected. So these are the two things that I can imagine. So I need your expert opinion regarding this question. Thank you so much.
Thank you so much, sir, for the wonderful presentation made by Dr. Saurabh and a detailed explanation of the case by you sir. The house is open for questions. Dr. Ashok Bhardwaj, sir, you have a question?
Just a simple question. Dr. Malay, who paid for the cost of medicine?
Sir, clofazimine, rifampicin is available from the program. Yeah. Initially, we help the patient getting imipenem from the hospital supply, but ferropenem and sevdenib the patient needs to buy. I also want to say initially we also tried tigecycline because tigecycline is a drug whose intercellular concentration is very, very high. Though the MIC is 2 showing resistance, but we tried it, but because of in-season nausea, vomiting, ultimately we have to stop tigecycline also. So majority of drugs were available from the program, except few like ferropenem and sevdenib, which the patient needs to purchase.
I want to clear it here that in some cases, if the medicines are not available from the program, then the state TB cell has promised that they will buy the medicine and procure it and give it to the patient whenever required.
Right, sir.
Perhaps you could not take up with STC, state TB cell. Okay. Thank you. This is my question only. Okay. Thank you. Thank you for wonderful.
Yes, sir.
Nita, may I come in?
Yes, sir. Please, sir.
So, first I should compliment Dr. Saurabh, who is a PG, and then Dr. Malay Sarkar, who is a good friend of mine, for presenting a very interesting and very well presented case, I must say. But there are certain questions in my mind. I think, as I have heard, she's about 60-year-old lady must be quite thin because the BMI is very low. And the asthma, as he said, she had problem of 3 4 issues. One is she's a background. She was known case of asthma, I believe, whatever presented. And but asthma usually a disease from childhood at early age. But as I can listen from the history, that breathlessness was just for about 4 years. And so probably history we have missed that during childhood or at the early age, this asthma might be persisting. That is one of the reasons because and for asthma, I don't know in Hamirpur or in Himachal Pradesh, at least I can vouch from UP, from where I belong to. A lot of steroids are used. Even in this case, history-wise, systemic steroids were used for for some time to treat asthma and to suspected ABPA. That was so probably history must go back to the childhood. You must ask in detail. One issue. Second issue, you are talked about ABPA also. I agree that every long-standing case of asthma should be excluded for ABPA. It was not clear to me from the test, but Dr. Mala, you told me that Aspergillus panel was negative. Means I believe specific IgE against Aspergillus and specific IgG against Aspergillus both were negative. Our specific IgE was positive. That was my another query in this case. And then the ball, I don't doubt about the diagnosis, but then I have seen many cases and I have read also that I was reading one of the meta-analysis of the false culture positive from from ball itself because of the contamination, because of the not proper use of bronchoscope, proper maintenance of the bronchoscope. This is a word report. They say around 9% of the patient, even the contamination may occur with MTB and the NTM. So that could be another challenging issue in this case that but as patient responded, so now we cannot doubt about the diagnosis of NTM because culture was positive. But that is the one query always comes to my mind that because this report is globally has been there about 9% patient. And we see now day-to-day clinical practice sometimes also that MTB is positive on TrueNat or in Gene Expert and there is no hardly any disease. So contamination is possible, especially with the bronchoscopic samples. Although I know that bronchial vas or bronchial aspirate are the gold standard. One sample, if it shows culture positive, it is the gold standard for the diagnosis. As far as treatment front, I hope Dr. Malay, you did very well. Although the reports were adverse, many of the drugs they have adverse, but you have used best possible combination and which I think has shown clear response. The another thing you raised a question that why she developed TB again. To my understanding, there are 2 3 issues in this lady. One, she is a diabetic. Because when you say the initial HbA1c was around 10. So diabetes many times remained uncontrolled. That is the one reason why, and in India, TB infection is very common. So getting a disease is not very uncommon. So that will be one. And second, she has immunocompromised also because of the long-term use of steroids in past. And so that may be the reason why, and you also explained beautifully competition between NTM and the MTB, and NTM was controlled and then MTB occurred. And unfortunately, both the episode has responded very well. That is a good point. But another point comes to my mind, which I think Saurav or Amala can answer. You have to use the anti-asthma drug effectively. Also, whatever treatment you have used, anti-asthma drug should, because it appears to me C is a baseline case of bronchial asthma, and you have to, ABPA, it is not once suppose the diagnosis is tests were negative. So as the aspergillus is a very ubiquitous fungus, so we have seen in our clinical practice that multiple times ABPA develops again, because aspergillus fumigatus is very common around us. So probably I think once again her ABPA must be excluded. Especially when you want to say the ABPA exclusion means specific IG and IgG against Aspergillus fumigatus. So that is another point. I think otherwise it was a very well discussed case and very well presented case. And I must compliment the whole team of Malay Sarkar for presenting this case. And this is very interesting also. And to me, it is very rare also. Such type of scenario is not very common, that Mycobacterium abscesses and the TB combining together subsequently. But the reason, to my understanding, C is definitely immunocompromised person, and that is why this is happening. My last suggestion is her diabetes. One has to look the diabetes every time. If diabetes gets uncontrolled, she might get these diseases again. So that is another point. Effective treatment of asthma, effective treatment of diabetes, and then frequent follow-up that may happen. About the drugs, I think Dr. Ashok Bharadwaj has already answered. Drugs, if the drugs are not naturally, these drugs will not be available. Then state STO can help in managing these drugs, procuring these drugs for management of such a special cases. One point was raised. I think Rupak will answer that point. That it took about 6 months to get the DST. So I think Rupak will explain about it. I need not to say anything. But this type of story we are listening throughout the India, that the culture and the DST reports are getting delayed. So that probably Dr. Bharadwaj is also sitting, so that we have to look. Otherwise, I once again compliment whole team of Malay Sarkar, and especially the resident who presented such a huge audience, such a great presentation. Thank you very much.
Thank you, sir.
Thank you so much, sir, for your taking out important points out of the case history. One of them is you highlighted very well about the risk factors of a patient who can develop anti-infections. Dr. Saurav, can you confirm us whether the patient was a known case of bronchial asthma? I think it was there from the history that patient was a known case of bronchial asthma, and she was on treatment for a long time before she acquired NTM. Am I right?
Ma'am, actually, she is a known case since last 4 years, and ABPA that time was diagnosed on the basis of ISHM criteria. All the panel was sent, and it was positive at Hamidpur. And she is having severe form of asthma. She developed severe attack almost every 2-3 months, and she was taking high dose of steroid, inhaled steroid also, and also oral steroid. So there was no childhood history in that case. So far this patient is concerned, and ABPA was diagnosed that time on the basis of ISHM guideline, but this time it was negative when she came to when she was admitted with us.
Yeah, I was going to the PPT. It was also mentioned the patient had taken itraconazole for ABPA in the beginning.
Yes, ma'am.
So that could be the reason that this time the panels are negative, or maybe patient might be cured, or
yes,
this is sensitization. Thank you, sir. Another important point which sir has brought into mind is the sterility of the bronchoscope, which is very important, I think,
we all should understand it's a sterile procedure. The bronchoscopy is a sterile procedure, but do take into consideration that.
Is very important regarding contamination. It's a valid point, but based on the clinical and radiological deterioration, we believe that a MTB complex real case, not contaminant. Though it's a valid point, we have to maintain sterility and disinfectant properly while doing bronchoscopy.
Yes. So your patient was symptomatic and do have
radiological deterioration.
Yes. So there's a question in the chat box. Dr. Kamal Sen has asked, can you do an LPA for NTM cases to reduce the turnaround time, particularly in extrapulmonary NTM cases?
Ma'am, LPA for detection of the resistant and the subtypes, subspecies, LPA has got role, particularly inducible resistant for macrolide detection. LPA has got role. It can also help in detection of mutational resistance for to macrolide. So it can shorten the time period definitely. Rather than waiting for 14 days culture to grow in the presence of macrolides to detect inducible resistance, LPA can be helpful to some extent in reducing the time period.
So why was it not done in this case?
Ma'am, LPA, it should be specific for detection of NTM mutation, not the LPA we are doing for TB.
Yes, right. So there's another question. If we do not have a DST, DST takes a long time to come. What would be the regimen we should start in this patient? But we need actually species identification is necessary before we start any regimen as per the guideline.
It's a very tough question because DST report showing something really.
Yeah, at the minimum, we need species identification and then DST.
One thing is if we get slow grower, anti-TB drug more effective. If you get rapid grower, then antibiotic more effective. But ultimately, in this era, we have to base our treatment based on DST report.
Right, sir.
And in our country, macrolide being used right and left for all patients, including TB patients. That may be the reason why macrolide resistance so common amongst the NTM, because both conditions can occur together in a patient destroyed lung, bronchiectasis. He may be harboring NTM also, and we are using macrolides so frequently. That may be one of the reasons for macrolide resistance.
Yes, sir. Very true. So there's another question you mentioned in your explanation while synergistic effects of rifampicin and ferropenams.
Yes.
So Dr. Paresh Nath, he's asking that what is the you might have seen in some literature.
Yes, there are many literature. One study, a real case study based from AIIMS Delhi. And what happens, carbapenem in the Mycobacteria abscessus, there are two enzymes. One is penicillin binding protein, another is L-dependent, which makes the peptidoglycan layer. So carbapenem is based for the LDCT and beta-lactam based for the DDCT. So carbapenem break down the cell wall, allowing rifampicin to go inside the cell, and so this is how they act as a synergistic in a synergistic manner. And there are literature also, but let me tell you, most of the literature regarding synergistic in vitro in nature, there are few real patient-based study. So one study we have from our country, from AIIMS, that Mycobacteria abscessus. They have used ferropenem and rifampicin for synergistic action.
Thank you so much. So there's so much of learning from this single case. There's another question from STDC West Bengal. Sir is asking that MTB directed from BAL was whether it was viable or a DNF already MTB dead bacilli. But
yes,
it was culture was positive.
That's a very good question. I was thinking that am I wrong starting the anti-TB drugs because culture was negative. So it's possible Sir can answer, Dr. Rupak sir can answer, is possible. Maybe the dead bacterial, TB bacterial DNA was dead inside the granuloma. But why there is then clinical and radiological worsening if it is not live bacilli? So I also want fair view on this point. But dead bacilli, if there is no clinical radiological deterioration, then probably it's dead bacilli. We could have probably ignored this, but in our patient setting, we can't ignore with clinical and radiological definite deterioration. So I want fair view on this.
Thank you. Sorry, thank you very much, Dr. Malaya Sarkar and Saurabh for presenting this very good case. I think before we go for discussion, let us ask other people who have joined our district TB officers, colleague, medical officers, and medical college faculty about this case. This is a very interesting and challenging case. So I request that please put your, please ask your question so that we can discuss it better.
Sir, so there are no further questions in the chat box, and the house is still open for questions if, like sir has requested already. I think we can move ahead with this.
Yes.
Hello. 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 Hello.
Each case different. Each case has got its own challenges in not only in diagnosis but in DST as well as in the treatment. So as sir also said, the first challenge comes in obtaining the species identification of the case. So once we suspect NTM, like sputum smear is positive and you find gene expert is negative, repeatedly it is happening. So one starts suspecting NTM. And when you send it to the laboratory, they do some biochemical test. But all this process, the culture, first of all, culture being labeled as NTM, then the DST being, then the speciation of the species, and then the DST. It takes, as in the given case, easily in our own lab also, it takes 3, 4, 5 months. Initially, we used to get frustrated that why it is happening. But then when we go to the laboratory, then we realize they have their own challenges for the delayed the reports being coming. And I remember maybe 15, 20 years down the line, we used to send, our laboratory was also now doing it. They just started doing it about, I think, around more than 10 years back. So we were sending our samples to AIMS, to Jalma Agra, to Patel Institute, and sometimes there was discordance also. Now, as a treating clinician, you see, we have to take a call, we have to treat the patient. We cannot just wait for the laboratory. So then in that specimen should be enough for NTM. And for sputum, you need at least 2 samples. But as was discussed, the contamination rate is known. I remember we got 3 cases of the endoscopy done, and then there was not healing and was found to be having NTM. Within 2 months, we had 3 cases from the same hospital. So then I reported the matter to them, and then they found that they were cleaning, the water they were using for cleaning was contaminated. So we should not believe that once it's the endoscopic sample, even single specimen should be good enough to diagnose. Better, because you see, especially mycobacterium abscessus, it's a very severe disease. Response to treatment is poor, and in case you don't diagnose and treat on time, they can die also. So we cannot take it lightly. Whenever we have this, it's a nightmare for us. The MAC is easy to treat, and prognosis is usually good. But here, everything is a challenge: diagnosing, species identification, and DST. I'll come to the DST also. Like in this case, Dr. Malaya has already given a table where he has explained the drugs to be used. So if you have a documented macrolide susceptibility, then drugs have already been discussed. In the initial intensive phase, you need 3 or more drugs. out of which 1 to 2 should be injectables. And you know, injections are imicacine, imipenem, cefoxitin, tigecycline, plus 2 oral drugs which could be azithromycin, linezolid, and clofazimine. But in case it is resistance from the beginning, it is documented resistance, then these 3 drugs becomes 4 drugs. You start with 4 or more drugs. Injection from 1 to 2 becomes 2 to 3 injectables. Amikacin, imipenem, cefoxitin, tigecycline. And you know, I've been able to give tigecycline only in 4 cases. It's extremely expensive. Extremely expensive. So most of the patients, they are not able to afford it. Then comes the easiest and the cheapest is amikacin. But whenever there is a resistance to amikacin, then our hands are tied. And even imipenem, you see, imipenem, if you want to give for long, like we do for MDR TB, drug resistance TB, we actually speaking, we should be inserting the PIC line so that we can give it for long periods. Cost is high. It requires infusion for 1 hour in the morning, infusion for 1 hour in the evening. So it has all the logistic challenges in terms of cost, then PIC line insertion and infusion in the morning and evening. You can imagine who can do it at home. So again, it's a very difficult to choose. Cefoxitin is okay, comparatively it is cheaper. Now, next please. Now, when you come to the resistance, I'm sure most of you know, but just to repeat, you see there is something called inducible resistance. Here, what exactly is that if you test on day 1, 2, 3 or so, then they will be susceptible. But if you do the test after 14 days, then you will find it is resistant. And we never do culture after say repeat, we don't repeat after 14 days. So in case you have done the midget culture, and the DST, so and we have done it in the initial 2, 3, 4 days, as usually happens, this will be reported as sensitive. While actually it was inducible resistance means at 14 days if you do, it should have been resistance in inducible resistance case. But if you use the WGS, the advantage is in case WGS shows the ERM41 gene is present, then it tells us this is inducible resistance. In the beginning, it may show sensitivity, but at 14 days or so, this will show resistance. So by using the phenotypic method, we can falsely label the case as sensitive while actually it is resistant because we do not have the mutation analysis on phenotypic samples. So that we have to keep in mind. Now, second challenge in the treatment of NTM, especially abscesses, is that the phenotypic DST is reliable for 2 drugs, that macrolides and imicacin. If a good lab says resistance to macrolide, we believe it. If a good lab says resistance to amikacin, we believe it and we take our clinical decision accordingly. However, there is a poor correlation between the in vitro and the clinical outcome for other anti-TB medication for microbacterial abscess. This is known. So in that scenario, like in this case also, if you see all the anti-TB drugs for resistance, all, and this is not an uncommon thing. I've seen it many times. Report comes and the good laboratory says resistance to all. In this case, it was only intermediate susceptible to imipenem, otherwise resistance to all. So now the treating physician is cornered. Number 1, these reports come late and you have to start the treatment whenever you are having the patient in front of you. Maybe within 3, 4, 5 days you have to start. And like in this scenario, if the laboratory showing resistance to all, then you have to choose as per based on your experience, based on some literature, that what drugs to be given. Ideally, what I tend to do is amikacin in case it is susceptible, definitely it is there. Otherwise, cefoxitin, then clofazimine, linezolid, they are my first choice. Even if they are resistant, because I have no other choice, they are easily available, and keeping in mind the long-term treatment, we choose them. Amikacin, if resistance, I do not use it because as per the theory also, amikacin resistance means it should be treated as resistance. Same thing with macrolides. If lab says it is resistance or inducible resistance, we should not be choosing it. Imipenem, as I said, I tend to use it, but I think out of these 50, maybe I have used it only about 20, 25, because again, as the challenges which I have mentioned. And then among the inhaled the amikacin, it is written all over the documents, whether ATS guidelines, IDSA guidelines, or clinical practice guidelines. But in India, inhaled amikacin is not available. And some people, there was only one article rather shared by Dr. Malaya only, where they have used the amikacin, the rescue as inhaled medication, but this is not to be done. So, I mean, we discussed this case together. So, ideally speaking, it should not be taken as a good drug in case we are using the rescue of amikacin, which is not rescue, the NQ available in the market. So, that should not be used. So, the drugs are very, very limited and the disease is severe. So, then you have to choose this. Next, please. Then you have to choose drugs accordingly. Now, coming to Dr. Sarkar, he used in this case ferropinam and rifampicin. And as you already mentioned, there are reports that they have synergy. When they use together, they have synergy. Although the individual MICs of ferropinam and rifampicin are quite high, but when they are used together, the MIC could be one reason for choosing this. And in the ferropinam 2 mg BD in AIDS, they have done some studies. And also, if you see the clinical studies, by combining ferropinam with amoxicillin acid plus rifampicin, they demonstrated early bactericidal activity. And there was a randomized clinical trial in 2023 in drug-sensitive TB. The ferropinam was used as a replacement to ethambutol in the standard regime, and they got non-inferior treatment success of around 88%. But in my own personal opinion, in my practice, I have not used ferropinam plus rifampicin because the clinical evidence is very, very poor. So I tend not to use this combination for my case. And also, it is known that you see ferropinam, it belongs to the beta-lactam class, and microbacterial abscess, it produces beta-lactamase. So then again, this is the reason that it may make in case of abscesses, the ferropinam may not be that much effective. Next. Now coming to bedaquiline in this case, bedaquiline could have been a good choice. It has not been used, and even the DST was not done. But we can believe that bedaquiline could have been a good drug for this case. There are some in vitro studies. Most of them are case reports. Some are some series. So, and as far as in vitro studies go, they show variable but promising activity in most of the studies. And it is typically used for bedaquiline in these studies as a off-label. And it is to be added to the multiple drug regime. Like we tend to use 3-4 drugs. In that, bedaquiline can be added. And it is taken as a part of salvage regime. The main indication when we consider bedaquiline is macrolide resistance cases, when there is extensive or disseminated disease, and when there are treatment failure cases. I remember in this case around 2 years back, Dr. Malaya had written to the Central TB division that he should be permitted to use bedaquiline in this case. I remember that they sent the case to me in the Central TB division, and I had my own comments where again I requested them that in this case bedaquiline could be considered, but somehow the Central TB division did not permit. So that was the reason I think Dr. Malaya could not give bedaquiline in this case. Otherwise, it could have been one of the good drugs under the circumstance. When you don't have any drug, you don't have the DST, then as an empirical treatment, as an add-on to the other drugs, it could have been a good drug. So, but it was not permitted. And you see, regarding the surgery, in all these cases, they have underlying diseased lungs. In this case, also had a cavity. Patient is a diabetic, often on steroids. So sometimes they can have repeated infections, whether pyogenic or MTB or NTM. So that is again a reason that in case person is fit for surgery, we should combine surgery also in these cases. After receiving a course of say 3 or 5 months minimum, and culture is negative, like in this case, culture became negative after 3 months. So after that, we may assess the patient for surgical fitness, and in case fit, then we should consider surgery, which can give lasting cure. So, having said that, what I want to conclude is that it's a big challenge diagnosing such cases, treating such cases, choosing the drugs for these cases, and having a balance between the cost and the efficacy in a given case. And each physician have got their own experience, their own sixth sense. I can say I have little more experience than others, but even I am learning now about how to manage them the best possible way, especially when we have the results of the laboratory coming so late, and lab most of the time saying resistance to all the drugs. Thank you. That's what I have to say about this case. If anyone else want to make any comments, most welcome.
Thank you so much, sir. And it's always a pleasure to listen to you, and it's full of knowledge and full of eye openers. Thank you so much. And your experience definitely doesn't match any one of ours in treating NTM cases. Uh, STDC Bengal, sir, who is a microbiologist also, sir, wants to throw some light on delayed culture results in cases of NTM and DST for long term. Sir, would you like to throw some light? You requested.
Good afternoon, ma'am and sir. It is indeed a good presentation. Actually, after getting the sample, to get a pure culture, you have to wait at least 12 days, 12 to 14 days. Particularly for DRTB cases, it will take at least 12 to 14 days. Then after that, you have to count for another 2 days to get it, prove it is a pure culture. So it will take another 2 days, so 14 days. And to get a DST in 14 12 days protocol, it will take another 12 days, so it means it comes around 26 days. So from the sample entering the lab and report, DST reports comes, strictly speaking it takes 26 days. So you can count another 7 or 8 days plus or minus. So at least 1 month is required to get a DST report. Thank you.
Thank you, sir. Thank you so much for your input.
Yes, sir. But you see, in practice, I've had the experience of AIMS, Patel Chess, Jalma Agra, our own lab. Usually, it is delayed by 2 to 3 months. Rather, I must say around 3 months before we have species identification and the DST. So, what is the reason for that?
Sir, sometimes it may happen, I'm not sure, that in the first culture it was not pure. And the prerequisite condition is to run a DST, you have to prove that your culture is totally pure, not of devoid of any contamination. So if it is found in the first culture it is not pure, you have to subculture, and in the subculture you might get a pure culture or not. So that is the laboratory process. So to in search of getting a pure culture, the maximum time is consumed. That's why sometimes from the lab we get after 1.5 months or maybe 2 months. That is for very unfortunate, but that actually happens. And particularly for the broth system, the liquid culture, the contamination is very high, and it is unavoidable also.
Thank you, sir. As you see, now I should be reminded of whenever we are after the laboratory. Why don't like what one challenge you said it. So they used to tell me, they used to tell me that it requires experience of months, not weeks, and maybe sometimes years to have to diagnose and to have the culture DST, whether NTM or whether tuberculosis. So you need sufficient experience because of all these challenges. So I mean, we agree with them that there are challenges, but still we'll keep on asking our laboratory to release the result as early as possible because we have to treat the patient. So, what anyway, after listening to you, we know another challenge which is there in diagnosing such cases and giving the DST report. Thank you, sir.
May I come in?
Yes, sir.
It was very well presented. One of the challenge was asked by the Malay Sarkar team about the Mendelian susceptibility. I want to know if any microbiologist can explain how it can help us to manage the case of NT.
May I answer first?
Yes, sir, please.
Actually, when a patient develop recurrent TB or infection by different organism, immunological susceptibility should also be considered. And we test it by sending interferon gamma level and interleukin 12 receptor analysis. It's not available in nearby center is PGI, and in one case we have sent this to PGI for the analysis. Not in this case, young patient with 9 times ATT, and it came negative in that case. So ideally we should know what is the underlying susceptibility in a patient.
Okay.
Yes.
I think Dr. Rupak has explained every point very well. But one thing, Rupak Singla, my viewpoint is that, as in this case, it took about 6 months to get the DST reports. I can understand what microbiologist from West Bengal has said very rightly, that there is a too often the contamination, and this is the culture gets not very clear. So we have to do it again and reculture but ultimately, ideally, it should take 2 through 3 months is a period which is can be acceptable. But beyond 3 months, there must be more reasons. I can understand. This probably a lab person might explain much better way that why the culture, why the DST culture and DST should take around 5 6 months. That is actually not maybe that number of labs doing all such type of specific work are not optimum, and so workload may be very high. That may be another reason. I don't know. This can be shared by a microbiologist better than rather than we clinician. We just shout on the microbiologist why are not giving this report. But I can also understand because I have worked very closely in KGMC with Dr. Amita Jain. Many times we have to fight and many times, but we can understand there are if and buts, lot of if and buts to get the culture and sensitivity report.
सर हम भी ना काफी लड़ाई करते हैं इनके साथ जाके, लेकिन फिर तो रुक जाते हैं क्योंकि दोस्ती के साथ करना ही ठीक है सर, क्योंकि
लड़ाई के तो करने काम ही नहीं होगा।
तो वही है कि सर we I mean gradually we are as we are maturing we are understanding they have some challenges. This
Yes,
one
definitely.
They don't want to delay the reports as one of the challenge was described just from West Bengal. So there must be some challenges in the laboratory that that the reports are being delayed. But for clinicians, sir, as you said, it is too late to have a report, say after 3 4 months. By that time, we already have taken a decision about the drugs to be chosen, about the duration to be given. So let's hope we have some this molecule like WGS. It can help us in case we have reliable WGS within say, and the sputum is positive. Then in these cases, the TNGS, etc., they can give the species identification as well as the drugs which could be effective. So, as per our national program, also after the BPLM came, the CDD had a vision that we'll have sufficient number of labs for the TNGS, and that will be rapidly scaled up. But however, again, there are some challenges that so far we are into 15 months of BPLM, but we are not able to get the clinical report from these labs which can be used for the treating the patient. So I hope that in the next few months we'll have TNGS at least in some of the laboratories and we can make use of them in treating our patients. Thank you.
Thank you so much, sir. And to conclude today's clinic, okay, Dr. Rajiv Tandon, you want to ask a question?
Yes, ma'am. I would like Dr. Singla's opinion on Dr. Malay Sarkar's last issue to be addressed, the future prospect. I think he has already addressed it. I was interested in knowing what should be the future prospect of role of WGS in these kind of cases.
Thank you, sir. Okay.
Yes, thank you. So I think we do not have any more questions from the audience. We can close this session, and the take-home message from today's clinic is yes, both NTM and PTB can coexist together, and we need to identify the risk factors for NTM, low BMI, poorly controlled diabetes mellitus, a chronic patient of bronchial asthma who has been taking a steroid on and off. So history of steroid is important. And yes, we should avoid any misdiagnosis and should take into consideration about the sterility of the sample which we are sending to the labs. We should not make a diagnosis just on the basis of the lab test. We should also take into consideration the radiological factors, the clinical presentation of the patient, and along with the DST pattern and the lab reports. So with this, we end today's clinic, and we would like to have our closing remarks from Dr. Bhardwaj sir, who is Chair NTF. Over to you, Bhardwaj sir.
Thank you, madam. Thank you. First, I want to listen from Dr. Singla. Is there any documented role of bedaquiline?
Yes, sir. There are studies.
So, it is my earnest request that we should take this to the National Technical Expert Group. The role of bedaquiline in such cases, we should discuss it there, and get it approved from Center TV division. So this is my
Actually, sir, it's an off-label use, so it has to be done case to case. It's an off-label use.
But we can discuss in NTS.
Yes, sir.
So then you have to advocate it in that meeting, because you are also part of NTS, so you have to advocate it. So thank you. First of thank you. I want to thank Dr. Neeta Madam, Dr. Rupak for wonderful comments as always. Dr. Rajinder Prasad for his expert comments. I am coming last to my colleague, Dr. Malay Sarkar. So it was a wonderful case. So presented by Dr. Saurav, his postgraduate. So I was astonished to listen to him. So fluently he presented this case in excellent manner. Interesting case. So thank you, Malay. Thank you, Saurav. So
Thank you
so
sir.
much,
Thank
sir.
you.
thank the everyone. But I am pained to see today that the attendance, though I personally sent email to about 800 persons, sent personal email to 800 persons, but attendance never went above 180. So it is sorry state of affair. Even my own state, I telephoned everybody, wrote in the group, sent individual email, but no chest physician except Malay Sarkar joined. So we'll take action in this. So thank you very much. Thank you for everything. Thank you, Nita Madam. Thank you.
Thank you, sir.
Thank you, sir. Dr. Rajiv Tandon, sir, your hand is still raised. You have more queries? Okay, so with this we end today's clinic. I would like to thank each one of you who has taken out time and joined this clinic. I would like to thank Eco India for supporting us for the knowledge dissemination in tuberculosis across the country. And thank you, team from Himachal Pradesh, Dr. Malay Sarkar sir's team, and Dr. Saurabh, wonderful presentation. And we have shared a link in the chat box for feedback. Please do give us your feedback so that we can further improve on these clinics and for the, of course, the betterment of our own community. And with this, thank you so much. Thank you.
Thank you so much.
Thank you, everyone. Thank you, Mala. It was a very nice case.
Thank you, sir.
It was really treat to listen.